Good morning, everyone. My name is Pravina, and today I'm going to discuss the case of Mrs. Casey, a 19-year-old female who is presented to the emergency department at 9 o'clock in the morning and later required a medical emergency team call at 12:30 hour due to significant clinical deterioration. In this presentation, I will focus on four main areas. First, I will identify the important clinical signs that led to medical using ABCD assessment framework. Second, I will explain the pathophysiology behind her deterioration. Third, I will discuss how her different health conditions affected and worsened her overall condition. And last, I will outline the evidence based management priorities used to treat her. Here in this slide, Mrs. Casey was previously admitted to intensive care unit due to diabetic ketoacidosis or DKA and has history of type 1 diabetes mellitus. In addition to this, she had endometriosis and had laparoscopic surgery before 7 days. Because of the illness that caused her decline is probably related to this recent operation, which is clinically relevant. She had been experiencing fatigue, headache, nausea, vomiting, diarrhea, lower abdomen discomfort, and frequent urination over the past 2 days. For past 5 days, she had fever. During assessment, she appeared confused and incorrectly mentioned that she was 42 years old. She was made kneel by mouth due to persistent vomiting and inability to tolerate oral food. The working diagnosis was moderate diabetic ketoacidosis with a septic focus, likely related to recent laparoscopic wound site. In this slide, I'm going to discuss about her clinical result. Using the ABCD assessment framework, several significant findings were identified that triggered the med call. While talking about airway, her airway remained patent and no immediate intervention was required. Regarding the breathing assessment, she had an oxygen saturation of 95% on room air and respiratory rate of 19 beats per minute. Close observation is important because individuals with metabolic acidosis may experience compensatory respiratory alteration to eliminate excess carbon dioxide from the body, even while oxygen was not severely compromised. The most concerning result was identified during circulation assessment. Mrs. Casey's blood pressure was 86 by 62 mm of Hg, which indicates significant hypotension, and it required medical. It met the medical criteria. Her heart rate was 46 beats per minute, which demonstrates sinus bradycardia. This result was clinically concerning because sepsis commonly present with tachycardia rather than bradycardia. The abnormal heart rate raised concern for electrolyte imbalance or cardiac condition abnormalities associated with DKA, diabetic ketoacidosis. She also had dry mucous membrane, flushed skin, and tapeted peripheries, which indicate severe dehydration and impaired tissue perfusion. Her Glasgow-Coma scale score for disability assessment was 14, and she was confused and disoriented. Her blood ketone were 7.9 millimole per liter, which shows active ketoacidosis, and her blood glucose level was extremely elevated. And here in the slide, while talking about the temperature, she has a temperature of 39.8 degrees Celsius and erythema surrounding the laparoscopic surgical site was found during the exposure assessment, where we can clearly say that it is an infection. Her lactate level was elevated at 6.3 millimole per liter, which indicates severe hypoperfusion and possible septic shock. Uh, Here, in additional research confirmed how seriously she was deteriorating. Acidosis was confirmed by arterial blood gas measurement, which demonstrated a pH of 7.30. The increased anion gap of 25 and negative base access showed ongoing metabolic acidosis associated with decay. Even though bicarbonate level remained close to normal, a systemic inflammatory and infectious process was supported by increased WBC count and C-reactive protein level detected in the blood. According to Joint British Diabetic Society for Patient Care, a urine analysis confirmed glucose-urea, ketone-urea, and extremely concentrated urine confirming severe dehydration followed by osmotic diuresis. Now, let's discuss the pathophysiology underlying Mrs. Casey's clinical deterioration. In type 1 diabetes mellitus, the pancreas is unable to produce insulin. Without insulin, glucose cannot effectively enter body cell for energy production, which result in severe hyperglycemia. In response, the body releases stress hormone, including glucagon, cortisol, and adrenaline. This hormone increases gluconeogenesis and glycogenolysis, further worsening blood glucose level. The body starts using fat as an energy source when glucose is not sufficiently utilized. Ketone molecules like acetoacetate and beta hydroxybutyrate are produced during the metabolism of fat. Miss Casey high anion gap, metabolic acidosis, low pH, and higher ketone level are all explained by buildup of this acid ketone. Osmotic diuresis, in which too much glucose in the urine remove water and electrolyte from the body, is another effect of hyperglycemia. This lead to concentrated urine, electrolyte imbalance, severe dehydration, and hypotension. This mechanism explains Miss Casey's altered neurological state, poor tissue perfusion, and dry mucous membrane. If potassium levels are not adequately controlled, insulin therapy quickly transfers potassium into cell, which increases risk of hypokalemia and cardiac arrhythmias. Here, we can see her post-operative laparoscopic incision site infection was most likely the cause of the septic component of her illness. The body released inflammatory cytokinases during sepsis, such as interleukin and tumor necrosis factor alpha. Dystrophic shock and hypotension result from this inflammatory mediator, extensive vasodilation, and enhanced capillary permeability. This explains Mrs. Casey's reduced tissue perfusion, low blood pressure, and flushed complexion because of insufficient oxygen delivery to tissue. Her increased lactate level caused cell to transition from aerobic to anaerobic metabolism. Elevated lactate is related to higher risks of mortality and is also important indicator of septic shock. She has bradycardia, which was concerning because it is not typically seen in sepsis. Therefore, urgent cardiac monitoring and ECG assessment are required to exclude conduction abnormality related to electrolyte imbalance, particularly potassium disturbance associated with decay. Miss Casey's deterioration demonstrated the complex interaction between multiple disease conditions rather than single isolated illness. Sepsis increased the release of stress hormone, which reduce insulin resistance and increase ketone production, which makes her decay more severe. At same time, decay impair immune function, reducing the body's ability to fight infection effectively. Here, her recent surgery and underlying inflammatory condition of endometriosis also increase psychological stress and systemic inflammation, contribute to both sepsis and decay development. In addition to this, we can see experience severe dehydration from multiple sources simultaneously, including osmotic diuresis, vomiting, diarrhea, and sepsis-related fluid shift. From a holistic perspective, Mrs. Casey's young age, confusion, inability to tolerate oral intake, history of previous ICU admission, increased her vulnerability, and highlighted the importance of multidisciplinary patient-centered care. Psychological support, family communication, and ongoing education regarding diabetes management would be essential for her overall care plan. Now, in final section, I want to discuss on management priorities. The first management priorities was hemodynamic stabilization through aggressive intravenous fluid resuscitation using 0.9% sodium chloride. Fluid therapy was important to restore circulating volume, improve tissue perfusion, and manage both like septic shock and dehydration caused by decay. This intervention was prioritized because untreated septic shock and severe hypovolemia can rapidly progress to multi-organ failure. A 12-lead ECG was also urgently required to investigate her bradycardia and identify any electrolyte-related cardiac abnormalities. If hypotension persisted despite fluid resuscitation, vasopressor therapy with non-adrenaline would be required to maintain adequate mean arterial pressure. Now, the second management priority was ongoing decay treatment. Intravenous insulin therapy was continued to suppress ketone production and gradually reduce blood glucose level. Detox infusion was administered concurrently to prevent hypoglycemia with ketoacidosis result. Potassium replacement and close electrolyte monitoring were also critical because insulin therapy can rapidly decrease serum potassium level, increasing the risk of life-threatening arrhythmias. Here, the third management priorities focus on sepsis management and source control. Blood culture need to be collected before antibiotic administration. However, antibiotics should not be delayed. Broad spectrum intravenous antibiotics should be commenced within 1 hour of recognizing sepsis in accordance with current sepsis guideline. The laparoscopic wound site also required ongoing assessment, wound swabbing, and review by surgical team to identify complications such as abscess formation or wound breakdown. Here, ongoing monitoring is important throughout Miss Casey's care. Blood glucose and ketone level require hourly monitoring to assess response to insulin therapy. Electrolyte and venous blood gases needed frequent reassessment to monitor correction of acidosis and potassium balance. Neurological observation, urine output, heart rate, blood pressure, and temperature are also require close monitoring to identify further deterioration and evaluate treatment effectiveness. Now, in this slide, I want to wrap up the case study. In conclusion, Miss Casey had severe deterioration and medical activation due to mild diabetic ketoacidosis, followed on by a post-operative septic infection, severe dehydration, hypotension, altered neurological states, metabolic acidosis, and septic shock found during the assessment. Her illness mentioned the complicated connection between sepsis, post-operative psychological stress, and decay. Now, to stop further deterioration and improve patient outcome, management require immediate fluid resuscitation, insulin and electrolyte therapy, early antibiotic administration, and continue monitoring. Thank you for listening about this case study, and I have listed the reference of this presentation here. Thank you.